So today I'm going to talk about supraglottoplasty for Laryngomalacia patients in a tertiary referral center. So before we start, let me introduce, Laryngomalacia, as you may all know, is the most common cause of stridor in the pediatric population. The classical presentation includes stridor with signs of increased work of breathing, cyanosis, apneic spells, snoring, and in severe cases resulting in airway obstruction and respiratory failure. It is also associated with feeding problems such as choking, regurgitation, aspiration, failure to thrive, and even requiring non-oral treatment. So therefore, it's not just merely a sound or noise. It really needs medical attention early. So we classify laryngomalacia by severity. There is mild, moderate, and severe. For mild cases, is usually just stridor alone. For moderate cases, it includes some mild signs such as coughing, choking, regurgitation, feeding difficulties, or mild obstructive sleep apneic symptoms. And for severe cases, those with apnea, cyanosis, failure to thrive, and severe OSAS, and even requiring ventilatory support and tube feeding, and resulting in cardiovascular sequelae such as pulmonary hypertension or even cor pulmonale. So what do we do with kids presenting with stridor at our clinic? First of all, we do, of course, a thorough history taking and physical examination, looking for any other signs of respiratory failure, any under-syndromal features of the child, and also any history of previous intubation. And then we do fiber optic laryngoscopy for all of our patients at our clinic, first step. So for the kids who have anatomical anomalies, on the first consultation through the fiber optic laryngoscope, such as stenosis, cleft, cyst, hemangiomas, or tumors, we would arrange them early on for rigid laryngotracheal bronchoscopy. For kids with milder symptoms or mild severity, which either have less of an anomaly in the larynx, for example, just isolated posterior excess mucosa, or some vocal palsies, dyskinesia, mild laryngomalacia, we tend to observe with active observation and reassess with endoscopy. So plus or minus prescribing proton pump inhibitors, because everybody knows it can aggravate the laryngomalacia and the stridor. And if the symptom does not improve or there shows a progression in signs of severity, we also arrange laryngotracheal bronchoscopy under general anesthesia. So for the classification, this is a very famous Hollinger's classification, only describing the morphology of laryngomalacia, and it describes into 5 types. But this was published in 1989. And right now, what we're currently using is actually rather the Onley's classification. It's probably slightly a few years later than what Hollinger's suggested, but we think it correlates better with the pre-op planning and also the type of supraglottoplasty we're going to perform. And it's easier for communication because it only has three types, mainly 1, 2, and 3, which is addressing either for type 1 is addressing anything in the posterior compartment, mainly the arytenoids, either it's insucking or it's just bulky. For type 2, it's talking about the lateral compartments, which is the Aryepiglottic fold. It's either insucked or it's tight and short. And for type 3, it's usually about the epiglottis, either it's floppy or it's just collapsing over the laryngeal inlet. So throughout international literature, actually Hollinger is still very famous and widely used among researchers. But now I think there's a shift in using Onley instead because it's just easier to correlate with our surgeries. So type 1 actually corresponds with posterior, and we do posterior supraglottoplasty for these patients. Type 2, we do lateral surgery by releasing the AE folds, and interior, we just do Aryepiglotpexy, either with laser at cold steel or stitches. That treats type 3 of Onley's classification of laryngomalacia. And what has been done worldwide, usually the majority are the disease is in the Aryepiglottic folds. So they either do a unilateral or bilateral release, and it counts for more than half of the supraglottoplastic surgeries in the world. And followed by the arytenoids, they can do unilateral or bilateral trimming. And the epiglottis is only accounting for 13% of the cases of supraglottoplasties worldwide. So what have we done in our center in the past 10 years? So what we've done is we try to review and summarize the surgical techniques and outcomes of supraglottoplasty cases performed in moderate to severe laryngomalacia. And we reviewed 51 supraglottoplasties for laryngomalacia in the United Christian Hospital at Hong Kong SAR between 2011 and 2020. So how we drew our cases is we have around 250 cases who are admitted due to laryngomalacia. So they have diagnosis beforehand in the clinic by our endoscopy. And then they come back, they're admitted for either investigations or consultations. And from those, there's 62 cases who have really undergone laryngotracheal bronchoscopy under general anesthesia, but 11 cases were excluded because either they were older at the time of surgery, which we assume that there are other more severe neurological reasons why they have laryngomalacia, and are usually very complex cases, does not attribute just by laryngomalacia itself. And we've excluded that for our analysis, and also some with very mild grade laryngomalacia, where supraglottoplasty was not necessary upon the LTB. So it was excluded. So in the end, we had 51 cases, and then we further divided into two groups. The single group with 40 patients, which is defined as having only supraglottoplasty as the treatment procedure. And there were 11 cases where the combined group, where we have done other airway procedures for this patient at the same session. So demographics of our 51 cases, actually male have a slight predominance of 1/0.8. And then majority, like over 75%, are termed babies actually. So a preterm may or may not have a higher risk factor for laryngomalacia itself. And also for the birth rate, there's more than half of them have normal birth rate. So we stratify into two groups. The demographics are quite similar in terms of the sex and the, but there's slightly more preterm kids and low birth rate kids in the combined and complex cases. For other congenital problems, they're roughly similar in terms of the percentage that these two groups have. Oops. And the presentation of these two groups of patients. Actually, the simpler cases with single supraglottoplasty surgeries done, they're like half of them have the severity of moderate to severe, while the combined, they're mostly very severe. So over 90% of them have very severe. And there are more kids in the combined group having preoperative respiratory assistance, either with oxygen therapy, high flow, and non-invasive ventilation, or even intubated or tracheostomized before the surgery. So what we do in the theater, so after the gas down, we insert a ventilating bronchoscope to do the LTB. And so you can see there is a ventilating tube here, and then the exoscope connected to the light source, and with all the instruments inserted in. So we insert and do our thorough examination down to the main bronchus before we intubate the patient and then perform our supraglottoplasties. For the operative findings, the majority of the laryngomalacia type that needed surgery were lateral. And there there is no posterior or anterior compartment alone surgeries that we perform. It's usually lateral together with either one of them. And compared to the literature that we have searched, actually, we have a much lower rate of treating the anterior diseases. We only have one case that's like 2.5% of the group, and none of them in the combined or the complex cases, which is different from what other centers in the world have done. And also our synchronous airway lesion rate is actually higher. It could range from 20 to 60%, and we're actually on the high side, even for the single group. And for the combined group, it's actually 100% of them have synchronous airway lesions. Here is a video of some synchronous airway lesion, and we took video of this children who have done their LCB for Laryngomalacia. We're trying to show you that this is actually a pig bronchus. As you go further down, you will see the right upper lobe bronchus opens or exits very high up and actually into the trachea. And this is one of the many synchronous airway lesions that we have encountered during the surgery. So the airway lesions can be divided into laryngeal or the tracheal type of lesions. For laryngeal, it could be tongue tie, glossotosis, granulomas, vocal cord webs, laryngeal cleft, vocal paralysis, subglottic cyanosis, which are more common. And then for trachea, it can be tracheomalacia, compression, diverticulum, a complete ring, or like we just shown you the pig bronchus. And mind you that having a synchronous airway lesion doesn't mean that these lesions would contribute, may contribute to the Laryngomalacia or the stridor itself, and it might not need treatment. So that explains a high rate of synchronous airway lesion in our simple groups, despite despite we not treating them actually. And it does not correlate with the surgical success rate. So we will discuss that in our outcome section. And for the complex cases, what do we do in combination of supraglottoplasty is like tracheostomy, balloon dilatation, granuloma, excision, cyst excision, and injection and cleft repair, even adenoidectomy for cases with severe OSAS presenting to us with stridor. So the operative details, the mean age of the day at the day of the surgery for a single group is much younger. Probably their disease is more simple, and they have probably one complaint. So it's about 90 days or so, about 3 months of life. And the combined cases are much older because they have a lot of issues to deal with before heading on to surgery. We do cases as young as 10 days, even for single groups. So it's actually, it can be done very early on in life. For the mean duration, is usually around an hour for simple cases, and for combined, it's usually an hour and a half. All cases were done with endotracheal intubation. One with in the complex group, they had a tracheostomy. So it gives more room and space for us to, it's just easier, secure airway before doing further surgical procedure. And we have done cold steel and laser ablation and treating the lesions. And our ratio is about 1 to 1. It's come down to surgeon's preference, and sometimes it's actually due to advancement of technology that we prefer cold steel instead. I would explain later. And this is another video of what we've done for Aryepiglottic fold release. So as you can see, the Aryepiglottic fold is very tight in this patient with limited movement. And then this is done with a cold steel technique and release the Aryepiglottic fold. Mind you, we don't only release the band that you see itself, but we either further advance and cut more tissue at the PE fold and also closer to, this is the bleeding of the superior laryngeal artery, but don't need to be worried because it just stops very soon, and we usually just stop it with some adrenaline neuropathies to stop the bleeding, and it's just quite quick. And then so we just keep on extending it until releasing into a 3D cavity instead of being a 2D lesion. And this is the other side. We just skip it because of time constraints. So the superior laryngeal artery goes through this. And so it's easily encountered. Actually, you will encounter for sure when you do it. And we're just trying to release it into like a web. So the scarring, we just try to do more, basically. And here is another thing we do to the arytenoids, that is a submucosal and retinal reduction. So here we're trying to open up a mucosal flap to expose the cuneiform cartilage of the arytenoid, and then we reduce it without taking away too much of the laryngeal mucosa to prevent scarring and edema. Oh. So we've opened up the flap, we're trying to pull it out and then try to, well, we will take some of the laryngeal mucosa as well if it's too redundant. But basically, we're just opening the flap, taking out the inside and then covering it back up. Okay. Over time constraints, let's move on. So regarding the cold steel and laser technique, actually early in the 2000 to 2010, actually laser was more popular amongst pediatric ENT surgeons. But then as the introduction, the advancement of the technologies, we've introduced high resolution exoscopes, so allowed us to see and visualize the larynx better with an endoscope with very good qualities of the images. And therefore, because of the use of the endoscopes, we changed back to using cold steel because it provides a better view of the angulated tissues. And therefore, laser technique has been less popular nowadays. And also, it is believed that laser technique, laser ablation of the mucosa would induce more swelling and hence lengthen the recovery and the resolution of symptoms of Laryngomalacia kids. And also there was an incident of fire at a children's hospital somewhere else. So then it just shifts its popularity. So here we still use laser, mainly on Epiglottopexy. This is a CO2 laser, and what we're doing is ablating the lingual side of the epiglottis, the mucosa, from the tip of the epiglottis all the way down to the root of the epiglottis. So it curls up as a result, and it curls up gradually. If you do it the other way around, so it might just retract up without exposing, like with a less favorable exposure. And the result would be seen immediately, actually. Okay, so for the outcome and complications, so after the procedure, we usually give a combination of steroids, either intravenous or oral, depending on the feeding method of the kid, and also proton pump inhibitors, and sometimes with antibiotics, depending on the surgeon for the duration and the combination. The typical recovery of stridor in a laryngomalacia kid is like, so they present about a month after they are born, and then the symptoms get worse, reaching a peak where the mother is scared, and then they get referred. And then by the time they come to us, it's variable due to culture differences. In Hong Kong, it's usually later because they're kind of more reluctant in seeking medical attention for soft symptoms. And so after they've gone through all the diagnosis and the investigations, and we really perform supraglotoplasty, usually the stridor resolves immediately on the first day. But then as the mucosal edema builds up, and then scarring, and also the healing process goes, and then the sound would come back a little bit, rising to a peak and up to like a week after the surgery. And then, but then it starts to go back down and usually resolves within 2 weeks of the surgery. For the Stridor resolution, that's how we counsel our patients. The simple surgery, supraglotoplasty groups, the Stridor resolution is usually about 1/3. So they resolve before discharge, and half of them persist from 1 to 3 months after, but only about 22% would have a Stridor persisting for more than 3 months, and that maybe account for other congenital anomalies of the airway that needs to be treated or other symptoms rising. And then for the combined, the complex cases, actually the rate is similar. Actually, it has about 1/3 of them also resolved before discharge, and with 1/3 persisted after 3 months. So overall, it's more or less the same. And for the length of hospital stay, so there's the majority, so 30 out of 40 patients actually discharged within 1 month of the surgery, and actually the mean is 8 days. So that we can counsel the kids and the parents that it's only about a week time for it to resolve and go home. And then there were, for the combined cases, actually the mean was also similar, but they stay on for other surgeries due to their congenital anomalies. And for weaning for respiratory feeding support, you can see that, well, the patients who initially had no or low respiratory support, they actually did not progress after the surgery, so they didn't need extra help after it. And for the ones who require high respiratory support, actually it's up to 80% that they have weaned the respiratory support that they initially had in less than a month. And some with prolonged respiratory support, like again, they have other anomalies that need to be dealt with. And also for the feeding, actually, it doesn't worsen the feeding problem, but at the cases with tube feeding already, actually 50% were able to wean off the tube feeding, which is quite promising. And for the complications we observed, there was one case, so about 2%, that needed reoperation because with a retinal reduction done due to the delay of weaning of respiratory support with high flow oxygen. And then the respiratory event is about 4%, with one suspected aspiration and one with some infection. We did not observe any serious complications, for example, post-op bleeding, laryngeal stenosis, readmission, or even mortality throughout the study in all of our cases. So in summary, supraglottoplasty results in 73% of resolution of stridor in the patients, with 1/3 of the patients achieving resolution of symptoms before discharge. And it also only leads to a short post-op hospital stay with an average of 8 days. And weaning of respiratory support can be as good as up to 80%. And also tube feeding would be reduced by 50%. And there is no major complication observed, meaning that the surgery is very safe. And there's a very, very low reoperation rate of 2%. So there are limitations to our studies. As you may know, due to probably Chinese culture or the perception that usually laryngomalacia is presented late compared to international literatures, and therefore we end up with more severe symptoms, more severe cases in our clinic with stridor kids, and therefore mild cases of laryngomalacia may be left out from this review, and also probably accounted for the more synchronous airway lesions that we have detected in our review. And also our sample size is also quite small, probably due to the similar reasons. So that further subgroup analysis may not be meaningful now, but in the future, if we have more cases, we can do it on the morphology, the gestational age, gender, birth rate, or age at operation in correlation to surgical outcomes in our future studies. So take-home message at the end of the day, I would I hope that people are aware that supraglottoplasty is actually an effective and safe surgery for infants with moderate to severe laryngomalacia. Supraglottoplasty is able to achieve good surgical outcomes with resolution of symptoms despite a high rate of synchronous lesion in our sample. And supraglottoplasty is also can be safely performed in laryngomalacia as early as possible in our series, like as early as 10 days of life. And also cold steel dissection is as safe and effective as laser ablation seen in our case series. So I'd like to thank all the audience for listening, and also particularly Dr. Victor Abdullah, Dr. Alicia, Dr. Jacky Low, so Dr. Leon Jin, all the NICU colleagues of United Christian Hospital, Guangwang Hospital, and Hong Kong Children's Hospital for supporting our cases pre and post-op, and all the guidance and the mentorship in this review. So thank you.